I think that one of the problems why doctors are not comfortable actually asking and addressing the issue of pain and the use of prescription opioids is they really haven't been trained on recognizing substance use disorders or understanding them. So they get afraid of prescribing an opioid because they think that the patient will become addicted right away, on the one hand. And on the other, you see the other type of physicians that actually are overconfident and don't see that there is a problem of prescribing an opioid on someone having pain. So you have the two extremes, those that are very afraid, I will never prescribe it, and those that actually say, no, there's no problem. And the reality is that a patient with pain can become addicted to their pain medication, but the other reality is that the use of opioids, certainly when you're using them for acute pain, is not associated with a risk of addiction on the one hand. And the second one, while repeated use can result in addiction, there are certain symptoms that can emerge that actually can allow you as a physician to recognize it, number one. And number two, there's also certain characteristics of patients that put them at higher risk. So if you're prepared to properly evaluate your patient about whether they have those risks or not, and once you prescribe them, to follow them carefully to actually be able to see if indeed an addiction is starting to develop, recognize it and treat it. I would say that the guidelines, right now CDC has come up recently with new guidelines, and they're actually very good. These guidelines are based on what the evidence is right now in terms of science, but also clinical, because unfortunately we don't have much scientific evidence on how to optimally actually follow up patients, how to optimally prescribe. But the clinical evidence actually is guiding these practices in ways that recognize that the current way we are prescribing opioids is inadequate, is in part responsible for the diversion, the overdoses. But on the other one, that we don't have many alternatives for patients with severe pain. So opioids can be valuable under certain conditions, and the CDC guidelines guide us there. But the other one is too, there is inappropriate training of physicians, whether it is medical students going through medical school in order to get their degree, or specialties, and even specialties that deal very much with the issue of pain. The CDC guidelines are very new, so we actually do not know exactly how that's going to be influencing the pattern of use of opioids in our country. One could argue that if a physician, for example, feels uncomfortable in periodically monitoring drug consumption in their patients and having urine screens in order to see that, in fact, they are not taking other illicit substances, that would make him think maybe this patient is at greater risk for becoming addicted, because to start with, he's already taking other drugs. The extra work that it may require to ensure that your patient is not, for example, taking benzodiazepines or drinking alcohol, which could be at higher risk for overdosing. All of these issues make some doctors say, do I really want to treat patients? But I think, again, it's like anything that you come new. If you learn about it, if you get educated, you will feel comfortable. And I predict that if we are able to educate physicians on how to properly use these guidelines, such that they feel comfortable using them and prescribing, we will improve the outcomes. In psychiatry, we have, in general, not assumed that this is something that is within what we do, but the reality it is. Many of patients with mental illness suffer from chronic pain, and particularly vulnerable are patients with depression, and patients with chronic pain very frequently suffer from depression. Moreover, we also have to recognize that chronic pain, severe chronic pain, is a high risk for suicide. And those psychiatrists have an opportunity to actually play an important role in helping improve the outcomes of patients suffering from chronic pain, whether it is comorbid with a mental illness or whether the symptoms of depression and suicidal thinking emerge as the patient in distress actually start to contemplate terminating their lives. That needs training. We don't really properly train physicians, as I say, in specialties, and we don't train them in psychiatry or even anesthesiology or even in neurology, which is one of the disciplines that actually is involved with the management of chronic pain. We should be more proactively involved in engaging our patients regarding even starting by assessing whether they suffer from chronic pain. We come to recognize that in terms of actually interestingly, the neurocircuitry that is engaged with chronic pain, the networks, the brain regions, are basically the same that get engaged in psychological pain. And there is a tremendous overlap between physical and psychological pain. So it behooves us to actually try to be able to help our patients in ways that they will improve their outcomes. Because if a patient has chronic pain or pain and is depressed and we don't address it, it's going to be much harder to actually treat that patient. And also that recognition that a patient with chronic pain is at an increased risk for suicide.